Hey, everybody. Welcome to another Sunday morning conversation. Today, my guest is Lee Cubis. He is a clinical psychologist at Qube Psych down in Melbourne, Australia. So it's going to be an interesting conversation today. We're going to talk brain injuries. So thanks for tuning in, everybody.
Classic way to start off a Zoom. Hey, I was on mute.
Yeah. So
I'm good.
How are you?
I'm good. How are you?
I still have to go for my run today, but it's not too bad. It's the end of the day here, whereas yours is the beginning. It's
Yes. Yeah, I'm just starting up.
So I guess before I even start asking you questions, I'm obviously an American and you're an Aussie, but do you have free healthcare down there? Because we don't have that here. It's kind of really fucked up. I don't know what it's like, what you got down there.
We do have free healthcare here, yes.
So I guess what is the cover? Are your services, is your company covered by that?
So that's a really good question. So I work across a few different companies. So I work in research and I work in private practice, and some of the private practice stuff is covered. Some of it's partially covered and some of it's not, depending on the reason that somebody's coming in.
Is it expensive?
That's a good question. Again, that really...
Hold on. While you say that, I got to look up what the exchange rate is because I don't know what your dollars is compared to ours.
Oh, yes. Good idea.
All right. So tell me, like, what kind of cost it would be.
Just give me 1 sec. I'm just trying to fix my screen up here so that I'm not so bright and glary. But I'm on a Mac, which I never like being on because I never know how to make it work.
I don't know how to use Macs. I've been strictly PC. And when I was working as an architect, all my software was PC based. So I never had a reason to learn Macs.
Yes. Yeah. It's hard switching between the two when you're so ingrained in using one type. But I think that's about as good as it's going to get. So hopefully it's not too glary and distracting on my face.
Oh, no. You're good. You're good.
Yeah. So essentially, so if somebody goes into a public hospital in Australia, there's no sort of out-of-pocket cost for them. Theoretically, there might be extra bits that end up costing the money, but really the admission, the treatment, everything they get in the public hospital is going to be covered by our health system. Then you've got the private sector, which is where I guess once people are out of hospital and they've finished any outpatient rehab or any outpatient support that they're getting, then they will generally access their if they need ongoing therapies, for example, they'll access that typically through our private system. So I'm a psychologist, which means that I guess I do a few different roles in the private sector. So one is working with people with sort of mental health difficulties or things like anxiety, depression. But I also do a lot of work with people with disability, and people with disability may be a part of our National Disability Insurance Scheme. And our National Disability Insurance Scheme theoretically will pay the costs of people's therapies and supports that they need. So for those people, there's no out-of-pocket cost if they're seeing a private practitioner under that scheme. Then they're not going to typically have an out-of-pocket cost.
Oh God. So yeah, do you know how anything works over here?
I know that it's pretty messy and pretty difficult, and a lot of people don't get treatment they need, but I'm really keen to hear more from the perspective of someone like yourself who lives there and has obviously experienced it.
So first things first, I'm a very liberal person, so I'm all about universal health care for everybody. That is not quite a publicly shared opinion, because if you are on the right side, you despise that idea, even though for the most part, those policies benefit those people because they tend to be lower income, and they would benefit from those programs. But the propaganda machine kind of feeds that. So anyway, I hold the opinion of universal health care because I've seen, now I am on disability in US, but I'm not eligible for our version of Medicare. I looked it up. You're on Medicare, but ours is not quite the same. It's just the same name. But
Yes.
I can't get on either that or Medicaid. I never get them straight. But for over 2 years after I was declared disabled. So, and I happen to live in a state that is more, it is a red state. So they were red states, the ones that typically didn't expand their universal health care, the Medicare program to include more classes of people, right?
Mm-hmm.
So, and then with Obamacare, it was good intentioned. However, it ended up having really high insurance rates. So it was costing you an arm and a leg every month to pay for insurance, and you had really high deductibles, which I don't think you know anything about. You know what a deductible works in general, right? You have to cover certain costs. Yeah. Well, they were really high. So, the Obamacare became like not really that good. And if you were like me, who were disabled and you couldn't get on Medicare, you could get on Obamacare, but you wouldn't get subsidized by the government because you have zero income rather than having an income of a job that could be subsidized. So it got pretty messy. However, if you don't have any health insurance in this company, even though you are able to negotiate a little bit sometimes or declare yourself indigent, like my appointment with my psychiatrist, I translated this into your money real quick here. Let's see. So an appointment with just a normal appointment, with my psychiatrist is $250 your money, $175 mine.
Yeah.
My neurologist, who happens to be really, really good, one of the best in the country, and a regular appointment with her is like $600 my money, $850 yours. That's all.
Which really puts it out of reach for the everyday person, doesn't it? Especially the everyday person who's got a disability.
Yeah, and like I said, most people have kind of been fed the propaganda that we can't, we're paying for all, universal health care is bad. So it would make a difference in people who are like me, who part of the reason my recovery after my TBI was so messed up was I couldn't treat my TBI without having insurance. And the only way I can get insurance was if I kept working, but I couldn't keep working because I was pretty much incompetent at my job now. So I'd keep getting fired, but I couldn't treat, I was stuck in this cycle to where my attorneys, because I was involved in a lawsuit, I got hit by an SUV.
Right.
So my attorneys were like, fuck it, we're going to get you the best we can. So, but that was 2 years post TBI.
I think one of the issues that we have here is that even though we have this healthcare system that is, it's anybody can access it. You can get really good emergency care here, really good sort of acute care, and you can have rehabilitation in the hospital. For things like, say, psychiatry and even neurology, once you're sort of back out in the world, it's not as though you can ring up and get an appointment anytime soon in the public system. So issues that are considered not to be urgent will lead to these really, really long wait lists. So you'll have people sitting on a wait list for 12 months to see a neurologist, for example. And to see, if you're talking about psychiatry, you're very unlikely to be able to see a psychiatrist through our free public system unless you are in a really severe situation. And so that's where you do see, and things like medical costs, or things like psychiatry and neurology, aren't covered by our national disability insurance scheme because they're considered the job of the health sector. So we sort of have this division between health supports and disability supports, and our national disability insurance scheme won't cover medical or health costs, which means people are paying big out of pockets as well for things like psychiatry and neurology if they can't wait 12 months, 24 months to see someone within the hospital system.
Okay. Now, tell me about Qube Psych. Did I say that right? It's Qube?
You did.
Okay.
Yes. Yes. So Qube Psych is, it's my practice that I've been working in for about the last 5 years. So I'm a clinical psychologist, and I finished my PhD in 2020, but have been registered for a few years before that. But I guess my background is even long before that, is that I've worked in the disability sector for 20 years this year. So I started out as sort of a support worker. I worked as a nursing assistant, which is where I started to work with people with acquired brain injury. And so I did sort of studied over a long period of time. And then when I could start practicing, and I was working within the brain injury outreach team in the state that I was living in, as well as some other sort of hospital wards, and started doing a little bit of private practice, which is what Qube Psych is. And then in the last couple of years decided to build that up even more, to kind of meet a need within I guess within our sector for psychology supports for people with disability, and a large proportion of those being people with acquired brain injury.
Okay, so that's how you got your interest in brain injuries.
Yeah, well, my interest in brain injury started, when I was fresh out of school, I started doing disability support work. I was, your classic grade 12 kid who just had no idea what I wanted to do with my life, just knew that I didn't want to do any more study. I was like, I'm done with study, never doing it again. So did some volunteer work with a disability organization, got a job there quickly, loved it, realized, oh my gosh, this is just so much fun, really, really enjoyed it. And then I moved states. So I moved from New South Wales to Queensland a couple of years later, and started doing, the sector was very different in that state. And so I ended up doing a lot of in-home support for people. So I'd go out to people's houses and sort of just help with domestic tasks. But one of the clients that I was able to work with then was a guy who had an acquired brain injury, and he'd had it for about a year at that point. And I was 22, he was 23. I just saw a lot of, we had very similar backgrounds, and I ended up working with him essentially full time for about a year and a half, going out to his appointments, to all of his different rehab appointments, putting together a home therapy program that myself and the family and other support workers could follow. And it really got me so fascinated with the brain and brain injury, and how different it is from, I guess, developmental or intellectual disability that people have lived with their whole life.
Our system don't work like that, man. We don't have anything that works like that. Like, you have like social workers and those things of those nature, but it doesn't sound like those. You've got brain injuries down there. You sound like you've got it pretty good. You've got an advocate with you, basically. Is that kind of like more or less what your job is? Like being.
Yeah, but this is back in 2005, and we didn't have the same system then that we do now. A lot of this had to be privately funded by the person's family.
Oh, okay.
Yeah. So there was, back then you would maybe get, 4 to 6 hours a week of maybe like a support worker or carer or whatever. I don't know what you call them there, but I would call myself a support worker back then. And you'd have some outpatient appointments. So there'd be sort of physio appointments that you could go to at the brain injury rehab hospital. But honestly, for the people who were getting the more intensive rehab, where you'd have, regular hydrotherapy, physiotherapy, speech therapy, support work, all of that, it was often on the family to fill in the costs. So which of course then brings up the point that most families can't do that. So most families can't afford to.
So they have to be pretty much well off in order to be in that kind of situation to where they can afford it.
Either well off or willing to kind of sell everything they have and put everything they have into supporting this individual to get the rehab that they need.
Okay, but you said that's changed now.
That's changed now. So we've got the National Disability Insurance Scheme, which is a system that's sort of rolled out over the past decade, whereby, rather than in the past, the responsibility for disability supports fell within kind of state systems and sort of block funding, and you'd be allocated, you know, maybe hours per week at this place, or you'd, what the NDIS has done is, so it's a national scheme, and it provides funding for what they say are reasonable and necessary supports for people with disability to live an ordinary life. So live, and when they say ordinary life, they mean a life like anybody else. So your budget for your funding package is determined through a meeting with a representative of the scheme, who goes through a sort of semi-structured interview with you on sometimes it's a yearly basis. Now they're kind of moving it out to every couple of years, and they'll determine what supports you need, and they will then provide you a budget that you can use to purchase those supports. So you essentially get given what's called an NDIS plan, which is a document that says you've got this much money to spend on these things, you've got this much money to spend on these things. You don't actually get physical money in your account, but you purchase supports through this bucket of funding that you're given. So if, say, for example, if somebody gets $10,000 a year for physiotherapy, it's just a figure I'm making up, but if they get $10,000 a year for physiotherapy, they go and find a physiotherapist, and the physiotherapist will see this person, and they get paid with these NDIS funds.
We don't have anything like that.
No, you definitely don't have anything like that. And look, I won't pretend that it's anywhere near perfect here. You know, a lot of what I do in my work life is engaging with people who are NDIS, we call them participants, so participants of the NDIS scheme. So that's people with disability who receive NDIS funding for supports, and I do a lot of listening to what's going on for them, and it's an uphill battle. It's getting it implemented has been an uphill battle. People getting the supports that they actually need is an uphill battle, and people being able to maintain the supports that they need is an uphill battle, because, you know, it's an expensive scheme, and so there's always pressure to dial it back. And so the people with disability who are out there really fighting and advocating are having to do this constantly, and it's quite exhausting for them to keep fighting the fight. So yes, it's great, and it's a great bit of social policy, and I've seen in the people that I work with, it has absolutely revolutionized access to, particularly to allied health and psychology supports, because there was really nothing before in that way. But yeah, it's also not this utopian thing that's giving everybody everything that they need.
Now, does the government actually call it a scheme? Is it like written down that it's a scheme? It's policy like that? Yeah,
so it's essentially, so it's called the National Disability Insurance Scheme.
See, so let me pause you there for a second. You would never be able to sell that in America. Just every time, like, we Americans hear the word scheme, we think of it as in a negative light, as something bad, like a Ponzi scheme, that you're scheming of something. So it always has a negative connotation to it. So if they decided, like, if Joe Biden or Donald Trump or whoever if they were to phrase it like that, Americans are going to feel like they're getting scammed, and they're going to not be in favor of it. So I didn't know if it doesn't seem like you have that same problem where you're at.
No, I mean, I can see where, from a language perspective, where that comes from, because I could say, oh, you're scheming against me, or yeah, Ponzi scheme, I know what that is. But yeah, we don't have the same negative connotation for scheme. So if I said, yeah, I'm coming up with a scheme to, increase people's access to a certain type of service, it wouldn't sound sinister. It would sound like I'm making a plan. I'm doing something.
Yeah, it definitely matters here, because you would, if you use that word, you would automatically lose about 40% of your support just based on that one word alone, because anybody who is a Donald Trump type voter Republican is very distrustful of the government as it is, and you just called it a scheme. So yeah, you're not going to get a lot of public support, and that's why they have to get very friendly and politically correct in the words that they use here. But they would never be able to sell that whole program just based on that alone.
That's super interesting, because I think now off the top of my head, I think a lot of our
it's kind of rather than negative or positive, it's kind of a neutral word for you.
Yeah, and I think we have a lot of things with the word scheme in it when it comes to providing supports or that kind of thing. I'm thinking about one that I used to be involved in, which was sort of a continence AIDS assistance scheme. And I think that word has been around as in this sector for a long time.
Mm-hmm. So what is well, I had something else I was going to ask, and the thing of nature of the TBI, you forget what it was. So with Qube Psych, do you deal with a lot of TBI patients there?
Yep. So I would say the vast majority of people with brain injury that I work with are people with TBI. So I have a lot of experience working with people with TBI, but then also there's people with stroke, and then people with other types of brain injury. So I've done quite a bit of work in the neuro-oncology sector as well, so people with brain tumor and who've gotten their brain injury from either the tumor itself or the treatments associated with it. But a lot of people with who have had car accidents, people that have gotten their brain injury through being assaulted, falls off ladders, that kind of thing.
Yeah, I definitely, the thing is, as long as I've been doing this throughout the entire pandemic, because my neurologist told me that socializing is very good for me. Obviously, pandemic, lockdown, not seeing anybody. And I've been, I went through a breakup right before the pandemic started. So I have been completely isolated. So in order for me my doctor said, you can't repair any of the damage, but you could build new neural pathways by teaching yourself new stuff, rather than like lost where I was going with here. But she's like, but you need to socialize too. So what I'm doing with you, this is what I've been doing, and I found people that I've thought are genuinely interesting. And that I would basically be hanging on every word, learning something new and being engaged. So that would meet that social aspect too. And it just so happened that other people watch this stuff sometimes.
Bonus.
Yeah, I know. Not a whole lot, but they do. But
it is really interesting, because the topic of my PhD and one of my big interests is actually looking at the social impacts of brain injury. And so my PhD topic actually explored how brain, and so this was with brain tumor, how brain tumor disrupts people's ability to manage and maintain social connections, and how that then has a flow-on effect to psychological well-being. And essentially there's this huge body of research that tells us that social connections are really important, that a health issue like brain injury can really make it difficult to stay connected to other people. So you can either lose friendships, you can gain friendships, or social groups, I should say, not necessarily just friendships, and that has a really important flow-on effect to what life looks like after brain injury. So your doctor gave you some really good advice there, I think.
Well, I can tell you I'm a lot fucking weirder than I was before. There's definitely stuff about me that is not normal that I kind of deal with. And then it was funny, like when I went through that breakup, then I kind of lost a lot of friends because they were a lot of mutual friends. So I went into the pandemic already pretty isolated because I'm out on my own again and stuff. And where most of my friends were gone. And then it got to the point where it's like, man, I'm out here, I'm hanging around with 2 cats. That's it. That was my social, for a long time. I didn't see anybody. Everything, all your telemed appointments. I don't know if that's what they're doing down there where everything's virtual.
Yeah, and I think that's been really tough here as well. And I'm in Melbourne, where we've been sort of in some pretty strict lockdowns over the past 2 years.
That's at the bottom, right?
Yeah. That's at the bottom in Victoria, and we had 2 very long, very strict lockdowns, and our health system has kind of gone in and out of flux, so in and out of being very overwhelmed, and in and out of sort of having people furloughed to all different areas. And so, yeah, a lot of people who have got a newly acquired brain injury have not gotten the same level of face-to-face follow-up support. And there were long periods of time where you couldn't even have visitors in hospital as well. So you can imagine being in hospital, newly acquired brain injury, everyone's wearing PPE, can't have visitors coming in. It's been a really tough experience. I'm sort of meeting some people now that are newly discharged, so they were in hospital over the past year, who haven't had the typical experience that that they might normally get, where there's a lot more of that face-to-face interaction.
Yeah, I was trying to, before we talked, I was trying to get I've never had a good sense of what Australia, like actual size of it on a global scale was. It's about the size of mainland US. So when I'm like, wait, they're at the bottom. Before we got on before I asked you or accepted the invite for you to join the room, I'm like, how long does it take? I asked my Alexa, how long does it take to drive from Sydney to Melbourne? And she said 12 hours. I'm like, holy shit.
Yeah.
I thought it was a lot closer than that.
Yep. Yeah, no, it's a big country. And I lived in Queensland, Brisbane before, which is about another 13 hours north. And so you've got sort of Melbourne, Sydney, Brisbane, and then you've still got a whole lot of country above Brisbane as well. You've still got a whole other world up there. And that's just the east coast. You've got a whole other, a whole lot more country to the west as well.
Yeah, well, nothing in it though. I saw it's like I must feel bad for those people who live in Perth, because they're pretty isolated over there.
They are, and they've, so Western Australia, which is
are those people weird?
State,
are they weird, or is there something special about them, or?
Look, I will. What do you say over there? Plead the fifth on that.
Yeah.
One?
Okay. Sure.
I don't want to. No, they're not weird. I have a lot of colleagues over in Perth in Western Australia who I've never actually met face to face, but because of one of the I don't really like looking for silver linings in this pandemic, because it's been such an awful thing for so many people, and I don't sort of say that lightly.
Is that because they're not easy to find, or is just you'd rather not?
Well, it's because they're so far away, and it is a really long way away, and it's Oh wait, are you talking about the people, or are you talking about the silver linings?
The silver linings.
Oh yeah, no. Well, there's only one or two I can think of, and one is the ability for people to actually go online and do sort of video conferencing. We didn't really do that well at all before the pandemic, and now I think we've got a really good system here for doing doing telehealth, but it's also allowed me to collaborate more with health colleagues in WA, in Western Australia, which is where Perth is. But what they're going through now is that their whole state has really, their borders have been closed pretty strictly throughout this whole pandemic. So while the rest of Australia now has sort of the Omicron variant, surging through, Western Australia has still lived a relatively COVID-free life, but movement in and out of that state is very, very restricted. So yeah, there's a lot of people from Western Australia, a lot of people in Western Australia who would like to be able to move, but they haven't been able to for a couple of years because of the strict border closures.
So COVID can't get in, but they can't get out either. So
exactly right. But ask them what they think. I think there's a lot of people over there that are quite happy that they still get to live their lives while the rest of us are, scrambling around with, overwhelmed health systems and sick people and all of that sort of stuff. So
it's actually started to die down again here. It peaked maybe like a week or two ago.
Mm-hmm.
So, and it's starting to, recede here. So I think we're kind of reached the point where we're gone from, at least I have reached the point where I've seen it as pandemic, and now I see it as endemic. We made our effort to eliminate it. We failed. Let's just get used to it.
It's really interesting just from a psychological perspective, how because we would sit over here in Australia and we had, zero COVID for quite a while. And then we kind of, in Melbourne, where I am, we had, at one point we got up to 700 cases a day, and we were all like, oh, this is huge. And we went into this sort of 4-month lockdown, and we were looking at the figures in the States and seeing all these tens of thousands of cases and just being absolutely sort of horrified by it. But then once it's started here, sort of very towards the end of last year was when Omicron kind of started to really amp up over here, and the Delta variant had started to run through New South Wales and Victoria, which is sort of the Sydney and Melbourne states. And it's interesting how quickly you become less sensitized to those numbers. At first, when the numbers are flying up, you're sort of wide-eyed, and then after a few weeks,
you're looking at it from afar. I'm living here. I'm like, the numbers are so high on a regular basis that it seems normal,
Yeah, it becomes the new normal. You habituate to it, which is hard because
I plan on still wearing my mask in public places. I don't, we're doing away with the mandates as we speak. So, I think we are reaching that point where it's like, okay, it's an endemic now. So slowly but surely, but they're starting to remove all the regulations and mandates. So
yeah, I think we'll have them here for a while yet, which I think is, one thing that's, I guess one of the issues with people becoming desensitized to it is that we still have a lot of folks in our population that will get very, very sick if they catch it. And they're now kind of having to do their own self-imposed lockdowns. So, people with things like quite severe TBI who might have, difficulties, that their bodies will have difficulties managing if they catch it. They've kind of had to go back inside and watch everybody else out living their lives. So I'm very for the precautions, things like masks. It's a small price to pay to protect people.
Oh, so at Qube Psych, like what kind of things do you do with your patients? I mean, I don't exactly. Could you explain more about that?
Yeah, absolutely. And it's a really good question because I've trained as a clinical psychologist, and as I was going through my degree, I sort of initially signed on to a psychology degree that was just going to be 3 years. After a few years of working in disability, I went, right, if I want to get a job higher than what I'm getting now, I'm going to need to get a qualification. So I decided to study psychology, but I was like, I'll do the 3-year degree. 3 years in, well, you learn pretty quickly, at least here in Australia, that 3-year psychology degree won't get you very much in terms of ability to practice. So then did honors, and then realized that I love research. So then post honors, I always wanted to be a neuropsychologist. And then I guess during honors and some of the work I was doing, I realized that I really enjoyed research. And also I didn't really want to, neuropsychologists here do a lot of assessment. And I thought, no, I like assessment. I love assessment. But I also like doing practical stuff with people. I like doing therapy with people. So that's why I went down the clinical psychology road. And always with a view to do work with people with acquired brain injury. So what I do with people, if they're coming to see me as a new client and they've got a brain injury, I'll spend some time getting to know their background. I'll spend some time getting to know what happened to them. So the nature of their brain injury, reviewing maybe the medical records, reviewing any kind of previous assessments from a neuropsychologist or an occupational therapist. And I'm just loving that your cat is just sitting there, joining in the talk right now too.
Do you guys have Chewy down there? The pet services Chewy, or is that only in the States?
Oh, I don't know. No, I don't think we do.
Okay. So I have like boxes and boxes of litter stacked over there, And so she's standing on top of the boxes. The other one is sitting on the pillow over here. But yes, these are my two, well, they're amigas, friends here that have been hanging out with me all the pandemic. So
love it. Love it.
But
sorry, I'll continue. So yeah, I do. Yeah. So the first thing I do is just figure out what's brought the person in, a bit about their brain injury background, any kind of information I can get about what's going on for them. But then really importantly, I want to know about their whole history, you know, what life was like beforehand, what the brain injury, how it's impacted on their life now, and then really importantly, where they're at. So how are they feeling about life? What's brought them in to see me? What's getting in the way of them living the life that they want to live? And so the philosophy that I bring to the work that I do is all about, you know, finding out with the person what their values are. So what it is that they want to be about, what they want their life to be about, what their important roles are in their life, and then perhaps how the brain injury has disrupted that or is making it difficult, and then sort of working together collaboratively to come up with a plan to link in with those roles and values and important parts of their life that is going to make their life better. I'm a strong believer that the best rehabilitation happens when you're back at home, when you're in the community, when you're doing stuff that you love. So therapies are important, but they're not the full picture. You know, the things that you learn in a physiotherapy room, for example, you know, they're great for the physiotherapy room and they're important, but it's really when you're putting those into practice at home and in the community, that's when you really learn. That's when you really figure out how to adapt and do stuff. And similarly with things like speech therapy, I do a lot of cognitive rehabilitation with people, and it's all well and good to sit in the clinic and do it, but then it's like, all right, how are you going to go and practice this out in the world?
do you do those therapies out of Qube Psych, or do you have to send them off to or refer them to other places?
Yep, great question. So I do, I have my scope of practice, which if it falls within that, then I will do it. So I'll do sort of the cognitive rehabilitation work with people. If there's difficulties with communication, there's an extent to which I will work with that. There's an extent where it might be the role of a speech therapist to be involved as well. But if it's sort of, yeah, I will definitely do some work with people around communication, goal setting. But if there's, for example, a need for an occupational therapist, you know, say if somebody needs a piece of equipment or if they need some specific instruction on how to do a certain thing that falls outside of my scope of training, then I will refer on to somebody else. But I like to do that collaboratively. So we can have a tendency to work in silos. So I'm here, OT's over here, physios are over there. No one's talking to each other. I think it's really important that we communicate and that we're all on the same page with each other, so that there's some consistency amongst the treatment that someone's getting. And really importantly, that we're not doing a cookie cutter approach, that we are actually really meeting the person where they're at, listening to what they are needing and wanting.
Okay, because I'm trying to in sports terms, I was going to say you're more like, are you more like the quarterback, the person who's running all this, like pulling all the strings, telling what people we need to do here? Is that kind of your role? I don't know. I don't know Australian sports like cricket and rugby, so I don't know. I don't have anything an analogy.
I think that, so the work that I do as a clinical psychologist might be a little bit different to how other clinical psychologists work, but because my background is in disability and I have worked in case management roles, I don't do that case management. So I don't necessarily pull all of that together as a core part of my job, but I do some coordination in that way, because if I don't, sometimes nobody will. So it's yeah, if I am working with somebody and I think, right, this person would really benefit from seeing an occupational therapist who specializes in return to work, I'll help them link with that person. And I'll facilitate that. That's not necessarily what all psychologists are doing here, but that's what I will, that is what I will do.
Okay. Yeah, I think I covered anything that I wanted to ask you. It was very good. I appreciate it.
Yeah, good. It's been really good chatting to you as well.
Yeah, I don't know how many Americans you get to hear from that often, but at least I'm not one of the worst ones.
So we've got quite a few Americans here in Melbourne.
Oh yeah?
Yeah.
Oh, okay. I wouldn't
Yeah.
have known that. Well, it's not like they can get back home anyway, right? Because of the quarantine process and everything.
Yeah, well, that's right. That's right. How are things where you are now? What does your day-to-day life look like? Are you, because I know you're pretty into sports, are you able to get out and do all of that stuff yet?
So right now I'm dealing with, I've had depression off and on throughout this period of the TBI. I've done ketamine therapy for it, and
Wow.
it works. It's just something, something greater causes it to come back. Like everything that I read about it came true. Like after that first session, I felt like sounds were a little bit more crisp. It was a little bit more colorful. It didn't seem so drab and gray. And then, it worked as fast as I thought it would work. And, but I just, then something would happen to where it would come back again when it wasn't supposed to. A lot of really fucked up shit has happened to me over that time where it's like, okay,
Right.
I was going through deep depression and I used it, it worked. And then I ended up going through a breakup and it's like, well, let's throw some stuff that'll make it come back. But yeah, and so I'm not working out as much as I used to, and I haven't really enjoyed things. It's kind of like, I got a little bit anhedonia, not really enjoying what I used to do. So I'm trying to work through it, find that love again, but it's just not the same as it used to be. So
It's really hard, and I guess it's hard when you don't get that joy, then that makes motivation really hard as well.
yeah, and I'm very much a carrot on a stick type of person too. So if I don't have that, it's not as easy. But other than that, like my regular day-to-day life is, rather boring. I so the Americans with Disabilities Act, this goes back to we were talking about something in the beginning, to where you would like the whole where your first job you was about equality, right? To where you could be, the same thing goes through here. But the thing with ADA is it makes you to be equal to a normal person. The problem I had is I have really slow processing speed. So, if it takes a normal person a 40, because we work 8 to 5, give or take, usually more than longer than that. But it's usually a 45 hour week, right? 8 to 5, 8 to 6. And, a normal person to get that kind of work done, it takes me 60 hours instead of 40 to 45.
Yeah.
So there's really no way you could level out the playing field to where it would be equal for me.
Yeah.
I would be working more hours to just put out the same amount of work. And eventually I ended up being permanently disabled. So, and it's not like I didn't try to do anything else. I'm an architect by trade. So I'm pretty pigeonholed with what I can do. I applied to all kinds of jobs and there was only one kind calling, and it was the job I couldn't do anymore.
Yeah.
So,
because I guess that conceptualization of, that 40-hour week, 60-hour week, I mean, the vast majority of people I know with a brain injury experience fatigue, really significant fatigue. Is that something that you experience?
I experience a lot of stuff sometimes, and it isn't until recently that I've really been able to articulate everything that I had went through. It's fatigue, frustration. Like for me, what I was stuck with was, for the most part, 99% of the time, my only response was anger. That's the only thing that happened. There's that 1% of the time, it's where it was an awkward situation or something that was uncomfortable to me, and then I deflect with humor that always goes over badly because it's inappropriate. But that's like the 1%. The rest of the time, until 6-12 months ago, it was anger. That's all my brain could come up with. So yeah, I mean, it's like it was a difficult thing to deal with for my partner. Because how do you respond to that? I can't even tell you how I feel when all it comes out as is yelling. I mean, that's not what I'm thinking, but that's all it comes out as.
Yeah. Yeah. And look, it's so common after brain injury to have that experience and to have emotions kind of at the surface without you even really noticing that they've been surging up. They can kind of just come out without any real warning or any real gates or filters or anything like that.
Yeah, it's, it was a pretty vicious cycle until I started making some progress, but I guess I was not a typical case. I was one of the people who didn't get better in 3 to 6 months after, after their injury. It hung around for a long time. And there was a lot of, there's still stuff that apparently after 4.5 years, it's not going to go away. And I'm stuck with it,
Well, I think that's a really interesting point that you hit on there, because I know that over here there can be this, there's this talk that, you get 2 years, that after 2 years, you're as recovered as you're going to get. And I see people getting really quite nervous towards that 2-year point, thinking, oh my gosh, is this as good as it gets? But then having worked with people 5 years, 10 years, 15 years down the track, and I still see them making huge improvements. It's a really, I guess I want to, what's the word, like debunk that myth. There is no way that your recovery just stops and then that's it forever. I know people that are 10 years down the track that are still regaining skills and abilities, and it just is an ongoing process of recovery, especially if the more, I guess, significant the injury.
Yeah, and honestly, the first 2 years of mine, I didn't get any help. I had poor health care, and the insurance that I did have was not really that good. So not a lot got done. I mean, I needed, I had PTSD issues, all kinds of stuff. And I was looking at, getting therapy, at least counseling type therapy every 5 or 6 weeks. I said, I got to come more often. I'm too fucked up. I told the lady at Kaiser Permanente, I said, at least once a week right now. I'm like, I got a lot of stuff to work with.
Yeah.
So that's what I was dealing with, but I still wasn't getting great care until my attorney says, fuck it. We're paying out of pocket. We're just going to do this. So I did make progress after 2 years, but it did, what the law of diminishing returns is?
Yes.
To where you basically reach a point where there's no point to put any more effort in to reach that little bit that's left.
Yes.
So I realized after about a year of doing all kinds of therapies and stuff, I had reached that point to where I'm like, okay. So I did make some progress after 2 years, but everything else I've either gotten so used to that I found some way to compensate to get around that deficiency, or I've just come to accept what it is, and I don't even notice it anymore,
Yeah, and that's a really good, I think that's a really good thing to focus on there, that some people might be tempted to focus on sort of therapies and rehab to sort of get up to here, and they might spend 5-10 years of their life with their whole week revolving around these therapies, where what you're talking about there is developing compensatory strategies, accepting some things as they are. And it's not the same as resigning yourself to something, but it's accepting that right now this is how it is, and finding ways to compensate and then connect with the stuff that is important to you. And then what you'll find is often by doing that, improvements will happen, because you are living a life that's active and involved.
Yeah. And it wasn't, I mean, the compensating stuff, it wasn't planned. It came out of necessity to be able to do stuff. Like, yes, I hear you. She's deaf, and so when she wakes herself up, she'll let you know. My compensating stuff came out of necessity, like driving in Atlanta. I've got issues with depth perception, and I don't know how bad traffic is in Melbourne. I'm assuming it's like every other major city, But
Yeah, it's pretty bad.
yeah, okay. So Atlanta's got bad traffic too on the freeways. But in order for me to compensate for the depth perception, I kind of just well, later on, I just bought a new fucking car with better features. But I mean, for a while, I just kind of got comfortable with my range and then pushed my limits a little bit more because I knew my depth perception was off and I had space. So I just kind of got comfortable with it again.
Yeah.
But
Yeah.
otherwise, if I wasn't comfortable with it again, even though the deficiency remained, I would never be able to drive anywhere in this city.
Yeah. So interesting that point that you made about it's, the compensatory stuff came out of necessity. It was a necessary adaptation that you had to make. It wasn't sort of a pre-planned orchestrated thing. It was kind of, all right, I've got to do this to do this. Otherwise I can't do this.
So, a lot of, like I said, I've come, in a way, it's kind of like with a brain injury, you kind of turn into it's like a chimp with crude tools. You figure out a way to get around stuff or make stuff happen that other people would not have to do in the first place. So it's kind of like being a genius operating at half capacity to figure out how to navigate the world you live in now.
It's interesting. Yeah. And I think that a lot of folks, even though, you mentioned your processing speed earlier, has reduced, but then obviously there are other components of your intelligence that are still very sharp. And I think that's where people can feel like they're maybe less intelligent because things like processing speed or working memory are reduced, but actually they're not less intelligent. They're actually, like what you're talking about there is actually having to be very innovative and do a lot of problem solving and really figure things out. And that takes intellect, that takes intelligence.
Yeah, but it's kind of like golfing with a handicap, though. It's literally not as easy to come up with that stuff like when your average person could have. So,
yeah. Do you have many? Yeah, are you connected with other people with brain injury? Do you have groups there? Like, what's the situation like where you are?
Yeah, I've done support groups, a couple of them, but I didn't really find that they were the kind of the style that I thought would be best for me. I wasn't really getting anything out of it. I have met some people in there. I've met people through Reddit, believe it or not, which has been,
I believe it.
Yeah, it's been an interesting experience because I wrote every day. I love to write, and I used to write every day about what I was going through. And I was writing it like kind of how you would write a memoir, not like it was a diary, right?
Yeah.
So it reads like an actual book, and I wrote it every day for the first 3.5 years.
Wow.
So I've got.
Do you still have all of that?
Yeah, I've got over 400, maybe 500 pages now.
Wow.
An 8.5 by 11 typed.
Yeah.
So, I mean, but it's all based on raw emotion too. At least I got to the point now in my recovery where I can look at stuff with introspection and, hindsight and apply it to it. So it would not sound the same as before. But, I had 2 reasons for doing that. It was kind of like using it as a Rosetta Stone for my ex to be able to understand what was going on in here, because I can write really, really well. So, everything that I can't express verbally because I suck at having conversations on the fly, but everything I couldn't express verbally, I can hand you just everything that's here. Like, look, this is what's going on that I can't say,
Yep.
And the other reason was I thought I was going to end up in court at some point going to trial over the accident. So you're asking a guy where I could be 5 years down the road. It's like, because we only settled after 4. And it's like, there were so many details about my life over that time I wouldn't have been able to remember,
Yeah.
There's already a bunch of it that I already had forgotten that happened. So I needed some kind of record of it, but I don't know. I'll do something with it eventually. I don't know. I've debated I haven't read any of it again because it's kind of like pulling off a scab,
For sure.
Especially, what I had went through with my former partner. And so I don't know if I want to do that or not. It all depends.
Yeah. It sounds like it's still quite raw, understandably, underneath that. And the time has to be right to delve back into that. But what a lot of rich information that there'll be in there.
Yeah, definitely. If only I had something important that somebody would read it, right? But hey, Lee, thanks for coming on here today. This was a good talk for me. I learned a lot.
Thank you. I appreciate you reaching out, and keep in touch.
I hope you have a good day, because mine's about to end.
Yes, mine is just kicking off.
All right. Thanks again, Lee.
Have a good one. See ya. Bye.